Hello and welcome to the case-based educational curriculum. My name is Dr. Kanan from Stanford University Emergency Department.
And I'm Dr. Maha Duet from the Stanford University Emergency Department.
And today we'd like to talk to you about a case of shortness of breath. Presenting to our emergency department is a 25-year-old female with shortness of breath. She's having very difficult time breathing and is breathing very fast. So the first thing we need to determine is this an emergency?
Why is that important, Dr. Kanan?
Well, we want to determine if it's an emergency so that we can best use our resources and triage the patient appropriately so they get the best care possible. In this case, we feel that it is an emergency, and so we will act accordingly. So the next step, and what should we do next, is either to have her wait for a bed or move her to a bed immediately. And since we've determined that this is an emergency, we're going to move her directly to a bed. And let's see what she looks like. So this is our patient, 25 years old and having a very difficult time breathing. Her husband is there trying to console her. She's breathing very fast and uncomfortable.
She looks like she's really struggling to breathe. She looks like she's really struggling to move air.
Yeah, and that's what we noticed too, which is why we decided she was an emergency case and brought her right in. So then we need to determine what we should assess first. If you remember, we should go back to the ABCs with every patient who's presents in an emergency case.
And when you say ABCs, what do you mean?
Well, ABC stands for airway, breathing, and circulation, and these are really key components to assessing a critical patient.
And I'm assuming you do this for every sick patient?
Every single sick patient who comes to the emergency department. When I'm talking about airway, this is the portion that we look for any obstruction. We want to make sure that they're able to speak and to move air and open up their mouth, make sure that it's open and clear, make sure they're able to make noise and to speak.
So if they have an open airway, they're able to make sound and you can hear them breathing, is that right?
Exactly. If the airway is closed, you would think that there's some element of an obstruction, either their tongue or they're choking or something along those lines. In this case, she was speaking very short sentences, but her airway was open and clear. The next thing we do is we move on to breathing. Breathing helps us assess the air exchange, and we can tell in our particular patient that she was having rapid and shallow breaths. Her respiration was very fast at around a rate of 40, and she had wheezing in all of her lung fields.
When you say shallow, what do you mean by that?
She wasn't taking deep breaths. They were very short breaths, and thus she wasn't moving very much air with each subsequent breath.
I see.
It seemed like she couldn't actually get enough air with each breath.
And then I see the picture that you've shown there. You've got a normal bronchiole, which looks like a normal airway, and then one in a patient with asthma. That one looks a lot different. How is that one different?
So in asthma is really a disease of inflammation, and oftentimes when people present with asthma, they come in wheezing because their bronchioles are constricted and inflamed. And so you can see that the lining of the bronchiole is actually much more inflamed and red. And then there's also some secretions in there and mucus that makes air exchange very difficult for these patients. So to give you an idea of this, we're going to let you listen through our stethoscope. It's important to auscultate in all quadrants of the lungs, making sure that you take the time to really hear both inspiratory and expiratory phases.
Dr. Kanan, what noise are we hearing? It's very strange. It doesn't sound like a normal breath.
No, this is certainly not a normal respiration. What you hear hearing is wheezing. It's the quick movement of air through those constricted bronchioles. And we can hear in every lung field that we listen to, which is very classic for an asthmatic. And the third component of the ABCs is C for circulation. This is where we try and determine if there's appropriate blood flow that's going through the circulatory system. We look for pallor and cyanosis. We look for capillary refill, and we look for the pulses.
When you say pallor, what does that mean?
So pallor is an indication of the color of the skin. If you have good blood flow, your skin is going to look pink. If you don't have good blood flow, or for other reasons such as anemia, you may have very pale skin, and that would be an indication that you have of pallor.
I see. And how about cyanosis?
Cyanosis is best determined or best described as when your skin turns a little bit blue. And particularly around the lips, you can see it, and it first shows up there, but you can also see it in the fingertips as well.
I see.
You can test for that as well with the capillary refill by pushing on a finger or a toe and seeing how quickly the blood comes back. And finally, we really need to establish vital signs on every patient. And the vital signs that we determined were her temperature was afebrile, 37.6, heart rate tachycardic 115, her respiration rate was 30 tachypneic, blood pressure was normal, 110/76, and her oxygen saturation was 83%.
I see. So if I'm understanding you correctly, every sick patient should have a temperature, a heart rate, a blood pressure, a respiratory rate, and an oxygen saturation measured?
Absolutely. This is critical to trying to determine what to do next and how sick that patient is.
And just looking at the vital signs, it looks like her heart rate is fast, and that her respiratory rate is fast, and that her oxygen saturation is lower than normal?
Absolutely. So this gives us a real good indication that there's some disease process affecting her respiratory system. Her circulatory system, her blood pressure is normal, but her oxygen and her heart rate and her respiration rate are all increased. So to summarize, these are the things that we found just through that quick evaluation of airway, breathing, circulation, and vital signs. So now what should we do with that information? What should we do next? And the possibilities with critical patients are to place an IV, to put them on oxygen, and to put them on a continuous monitor. And in fact, we did all three. The IV was placed by the nurse, 4 liters per minute of oxygen via a nasal cannula was placed on the patient, and the patient was placed on a continuous heart rate and oxygen monitor.
So it sounds like in every patient you assess their ABCs, their airway, breathing, and circulation. And if they're sick, that you always place an IV, put them on oxygen, and do some kind of monitoring.
Absolutely. And this is key because if they're sick, we want to know if they're getting worse or getting better. And without putting them on a monitor, it's very difficult to determine that. Without giving them an IV, it's hard to give treatment. And without oxygen, their shortness of breath is not going to improve. So this is the patient on the monitor. Oxygen saturation is 83%.
And that looks like it's low.
Yeah. So we need to treat, and we need to be concerned about any oxygen saturation that's less than 90%. But 90% is even pretty is low normal, and anything below 90 should absolutely be treated.
So, and how would we treat that? If it's below 90, what should we do again?
Oxygen is the treatment, the first treatment modality of choice, and it's something that every hospital has and is easy to apply and can immediately improve the oxygenation. This is the patient being placed on the monitor, and an IV was established as well by the nurse. And like you said, just with oxygen therapy, the hemoglobin saturation has improved now to 89, even 90%. So that's a great and easy therapy that helps the patient out a lot. So now we want to find out what disease can cause wheezing and shortness of breath in this patient. What is the diagnosis that we're looking for? And there are different possibilities. Asthma is a possibility. Asthma presents with wheezing, cough, and it's episodic.
When you say episodic, what do you mean exactly?
So people with asthma present in bouts of asthma attacks. So it happens to them sometimes seasonally, or they have different triggers that cause it. And so in those patients, the actual disease presentation is in these short bouts of worsening wheezing and worsening respiration.
I see. So they probably have had this before if they've got asthma.
Most patients present actually as a pediatric patient initially, and 75% of asthmatics have presented before the age of 7 with some element of difficulty breathing. The other possibility is pneumonia. We need to consider that specifically with the signs and symptoms of rales, cough with sputum, and fever.
And when you say rales, some people, is that the same term some people use instead of crackles or crepitations?
Absolutely. So crackles and crepitations and rales can be used interchangeably. They're different terms for the same lung sound. It's very distinct and different from wheezing. It actually sounds almost like there's water, or a good description is actually crackles within the lungs. COPD is another disease that we need to consider that presents with shortness of breath as well as wheezing. These patients often have a cough with sputum, and importantly, many have a smoking history. Finally, the next disease that we need to consider is CHF, or congestive heart failure. These patients may or may not have wheezing, but they often have a cough with white, frothy sputum at times. They'll also have peripheral edema, jugular venous distension at the neck, and orthopnea.
Orthopnea. What do you mean by orthopnea?
Orthopnea is the term that we use to describe that a patient has more shortness of breath when they're lying down.
I see.
And
are these patients that like to use pillows? They might tell you they want to use pillows at night because they can't sleep flat?
Precisely. These patients, because of the disease processes, increased fluid within the lungs, they tend to sleep semi-propped up and have more shortness of breath when they're lying down. The final diagnosis that we need to consider is tuberculosis. This is a big problem, and we need to be able to identify it. This is a chronic disease and will present with often with hemoptysis and weight loss, distinguishing it from asthma.
And hemoptysis, is that when you have blood in your sputum?
That's correct. That's when you're coughing up blood, or you find blood in your sputum. So, to put this all together, let's look at these signs and symptoms side by side between the different disease processes. Like we said, asthma has a cough, wheezing, and is episodic. There's triggered symptoms. Pneumonia has these characteristics, but distinguishing it are the rales and sputum production, as well as consolidation on an X-ray. COPD has some similarities as well, but this is a chronic disease and can be distinguished with heavy smoking history. CHF, also a chronic disease, can sometimes have wheezing, but the real distinguishing factors are cardiomegaly, jugular venous distension, and peripheral edema. And finally, tuberculosis, another chronic disease that can have fever, but the distinguishing symptoms here are hemoptysis, weight loss, and the chronic nature of the disease. So if we're unclear of the diagnosis, there are other diagnostic studies that we can obtain. Do you know any of those?
Looks like you've got a chest X-ray, an electrocardiogram, and maybe some blood tests?
Yeah, these are great tests to help us differentiate between our differential diagnosis of shortness of breath. starting with a chest x-ray, it helps us differentiate between pneumonia, congestive heart failure, and tuberculosis. If there's an effusion or a consolidation, it might lean us towards one of those other diagnoses.
So if I was worried about pneumonia and in a person that might have asthma, I could use a chest x-ray to try to determine if it was pneumonia or asthma.
Yeah, you could and you should, because you don't want to be treating someone for the wrong disease process or missing something that they might have. It's possible for people to have asthma and another disease process. So if you're suspicious, you should get further tests to confirm. Similarly, with an EKG, you can differentiate between CHF or other cardiac causes of shortness of breath. And then a blood test, such as a CBC, can help differentiate between pneumonia and other processes, given that their white count may be elevated in illness. Let me take you through the chest x-ray of this patient. The first thing that we want to look at is look at the lung fields. Here's the diaphragm on the right, and we can see that it's a very clear, crisp diaphragm with no evidence of consolidation or effusion, which is really important. Also, you can notice that the heart is appropriately sized and not enlarged.
So that looks really useful. So that x-ray could show you if there's CHF or pneumonia, or if the lungs were hyperinflated, it might suggest asthma or COPD. And it also could show you if the patient has TB. So it looks like the chest x-ray is a very important diagnostic study in someone with shortness of breath.
That's right. And it's one of the best tools that we have, because oftentimes when we listen, we don't always get a clear-cut answer. So now that we have our differential diagnosis and we have some added information from the chest x-ray, we can choose which diagnosis that this patient has. And I think that asthma fits best here because the patient is wheezing, having a cough, and is short of breath, episodic nature. So what can we use to treat asthma? And there are a few mainstays of therapy that everyone should consider and use in our asthmatic patients. The first being a beta agonist, the next being steroids, and finally adrenaline. So beta agonist, which is an inhaled beta agonist, Ventolin or albuterol, can help with airway inflammation and open up the airways and make the patient feel much better. This is prepared as 2.5 milligrams in 3 milliliters of saline and infused through a continuous nebulizer.
I see. So this medicine, it's a bronchodilator, so it opens up those airways and makes it easier for the patient to breathe because the air can now get into their lungs?
Yes. So if you recall that picture that we showed before of the inflamed bronchioles, this medication helps open up those bronchioles and not only decreases wheezing, but more importantly, helps bring air to the alveoli and oxygenate the blood.
It sounds like we should use this patient in every patient who has asthma and wheezing.
Absolutely. This is a very important medication that needs to be used every time someone comes in with wheezing and the diagnosis of asthma. The next medication that's also important is prednisone. This is oral and is given at 1 to 2 milligrams per kilogram for not only the acute setting, but also 5 days later.
So if I was a 60 kilogram male, how much would you give me to take every day you said for 5 days?
So you can give 60 milligrams for a 60 kilogram male. And the thing to remember about steroids is that they don't work immediately, but they will work within several hours. And this is going to decrease inflammation in those airways and actually modify the disease process and make the patient much better.
So it sounds like you're saying that we talked about we should always give albuterol to patients with asthma. It sounds like we should always give steroids to patients with asthma as well.
Yes, I firmly believe that. sometimes people make the mistake of not giving the steroids immediately because you don't see an immediate effect of the steroids, whereas the beta agonists work immediately. The problem there, though, is that until you give steroids and until the steroids start working, they still have that inflammation within the airways. So we've given the steroids, and we've given the nebulized Ventolin.
Wow, she still looks really sick.
Yeah, so this patient didn't actually turn around. We had to redose the nebulized Ventolin, and still she's having a difficult time breathing.
So what would you do if you gave steroids and you gave the albuterol or Ventolin and the patient was still really sick with asthma?
Yeah, that's the key point. You know, we were able to tell that she's still sick. We had her on the monitor and we reassessed her and saw that she's still sick. So the next step when someone is not turning around and not improving is actually to give adrenaline or epinephrine. And this is given IM dose of 0.3 milligrams. This is really for your severe cases.
So 0.3 milligrams intramuscularly.
That's correct. And if we look, the patient is actually, after the treatment of all three of these modalities, has improved to an oxygen saturation of 95%. And so we continue to keep her in the emergency department and watch her progress. And this is a summary of what had happened to the patient. She came in with shortness of breath. We took her vital signs and assessed the ABCs. We put an IV in her, gave her oxygen, and put her on a continuous oxygen monitor. We got a chest x-ray, which confirmed our diagnosis of asthma, and we started therapy of Ventolin, steroids, and epinephrine. And over time, she felt so much better that she actually got some sleep and was lying down, no longer short of breath, and her oxygen saturation improved to 97%, which we all were very happy about. So let's take a step back and talk in general about asthma and some of the take-home points and pearls of wisdom. So you have to ask yourself, how do you know when to treat and when to send someone home who presents with asthma? And really, we should be treating all patients who have asthma with wheezing. Treat them with steroids and beta agonists. The only people you should send home is if their wheezing is resolved.
So if you've treated them with steroids and beta agonists and their wheezing is better and they're breathing a lot easier and they're able to walk around and their saturation is normal, that's a person that might be able to go home?
That's right, only if their wheezing is better and they're feeling comfortable. Now, some patients need to be admitted because their wheezing does not improve, and continued therapy of steroids and beta agonists inhaled would be indicated until they improve. But I would not send someone home until their wheezing is actually improved. The other pearl of wisdom is the question of how do you know if this is asthma or not? And like we talked about, shortness of breath can be hard to diagnose. So if we're not sure, then we need to obtain more tests to confirm that it's actually asthma.
And it sounds like an important one is the chest x-ray.
In this case, that's the most important, and it gives us a lot of clinical information. And also, should you intubate someone with severe asthma? This is a good question, but unfortunately, intubation is rarely helpful in these patients. What's more helpful is to repeat treatments several times. You can continue giving inhaled Ventolin or beta agonists, as well as give them steroids on a daily basis and adrenaline, because patients do not always respond immediately. And there are several pitfalls that we've encountered over the years of treating asthma. One pitfall is not sending the patient home with steroids for 5 days. And unfortunately, if we don't ensure that the patient has steroids for 5 days, because the steroids decrease inflammation and improve breathing, if the patient cannot get the steroids at home, they often get worse instead of getting better. Another pitfall is not getting a chest x-ray if the diagnosis is ambiguous.
And when you say ambiguous, you mean it's not really clear? Is that what you mean? Like you're not really sure?
Yeah, for example, if they have, if they come in with wheezing, but they also have a fever, and you're not sure if this is pneumonia versus asthma, it's really important to get that chest x-ray. You may be treating the wrong disease process, and the patient will get worse because you're treating the wrong process. The final pitfall is not placing a patient on a continuous monitor. So the reason why this is important is the patient may develop hypoxia, and in someone who has shortness of breath, it's difficult to distinguish between a lower oxygen saturation in someone who's already short of breath, and this could lead to decompensation and even cardiopulmonary arrest.
So it sounds like you want to keep them on that oxygen saturation monitor, even if you're giving them the right therapy, like steroids and inhaled beta agonists.
Mm-hmm. Yes, because this helps you determine if your therapy is improving them or not. It also helps you determine if they're getting worse and if you need further intervention. I wanted to address a few myths. Some people may think that only patients with severe asthma need treatment with beta agonists and steroids. So someone who may come in with only mild wheezing, they might think that they don't need these medications. And I'd like to clarify that, because mild and moderate asthma respond very well to beta agonists and steroids. And these patients benefit because they have decreased hospital stays and lower return rates. You can prevent their disease progression to severe asthma with these easy medications.
So it sounds like you're saying that every patient with asthma and wheezing that presents should be treated with steroids and inhaled beta agonists.
I firmly believe that, yes. And another myth that we see people is that oxygen saturation is not needed in asthma evaluation. We discussed this earlier, but the oxygen saturation helps us highlight patients who need more aggressive treatment and supplemental oxygen. So we really do need it on every patient.
So it sounds like you might look at a patient and may not know that you may know that they're sick, but when you see their oxygen saturation, it might tell you that they're really much sicker than you thought.
Yeah, it's hard for us to determine based on looking at a patient what their oxygen saturation is. And that's why this is critically important. The final myth is some people might think that chest x-rays are not needed in the evaluation of an asthmatic. And although that may be true in some instances, we really think that x-rays help rule out other illness possibilities such as pneumonia, COPD, CHF, and tuberculosis.
So it sounds like if you know it's asthma, you don't need to get a chest x-ray. But if you're not sure if it's asthma, or if it's the first time somebody's presenting with wheezing, it might be a good idea to get that chest x-ray?
Absolutely. You know, if it's the first time someone presents and they're in their 50s and they have wheezing, it's a pretty good likelihood that it's not asthma, and you need to look for another reason why they're wheezing. And so this is a very good test that helps us do that. So I wanted to thank you for your time and your patience, and I hope you learned something.
Thank you very much.